Hi, everyone. Thank you so much for joining us today. My name is Kayla. I'm on the marketing team at Wasatch Crest. Today, our Director of Utilization Review and Primary Therapist, Lindsay Fenton, is going to be presenting on advocating for clients' recovery to insurance companies. So it should be pretty interesting. A couple things before we start. You can find Lindsay's presentation in the handout section of your GoToWebinar control panel, and you're able to download that and take it with you after the presentation's over. Also in that handout section are two of Wasatch Crest marketing pieces. So we have a program overview that just talks about what we have to offer. And we also have an admissions guide, just a step-by-step guide to our admissions. And then please feel free to ask any questions during Lindsay's presentation, and we'll make sure they get answered. You can ask questions by going into the questions section of your control panel and typing it in, and we'll make sure they get answered by Lindsay. That's all I have for you guys today, so I'll hand it over to Lindsay to start the presentation.
Thanks, Kayla. So good morning, everyone. Thanks for logging on this early on a Friday to learn about advocating for insurance coverage, which is something that I actually really love. And every time I tell people that I'm an insurance advocate and that's what I do, I work with insurance, they kind of groan and I say, you know, I really like it. So I have a lot of passion for it, and hopefully you guys will learn some things today. So that's me. Hello. I am a licensed CMHC. That is one thing. If you have somebody that you hire at your facility advocating for your clients and doing the insurance reviews, it's really nice to have a master's level licensed clinician, which I am, because often insurance companies require to speak with a master's level licensed clinician. So it makes things easier. I specialize in trauma and addiction. I'm trained in EMDR and have been doing the authorization side for about 6 years. Prior to being at Wasatch Crest, I worked with a billing company where I kind of learned everything. I was there for a while, and it was a really amazing experience. I worked with probably 100 different facilities around the country. So part of my job there was doing a lot of training. I was a manager, so I did manage a lot of the department and the advocates, but I also did a lot of training as far as best practices, documentation, medical necessity, stuff like that. So I guess you guys can't see my screen, so should probably share that. Let's see, can you guys see my screen now? Let's see. Awesome, you can. Perfect. Sorry about that, guys. So let's start with the process. There's obviously, when you're doing insurance authorizations, there's a few different people involved when you're doing the whole authorization process or the whole insurance process. We have a verification of benefits, and then obviously, which is the beginning, you have the billing, which is the end, and then the authorization part comes in the middle. So obviously the first step when you have a client come in is you're going to want to obtain benefits through VOB, or verification of benefits. And this, in focusing on authorizations, is really going to tell you, obviously, if the client has the coverage, whether you're in or out of network. If you're in network, sometimes it makes it a little easier, but if you're out of network, do they have the out of network benefits? What are the benefits? What services are covered? And what the authorization process is. And when you do this for a while, you kind of know how certain insurance companies works, all their nuances, what you need to do, but verification of benefits is a great way to start and kind of figure out if the client's going to be covered. Obviously, there's the whole deductible and out-of-pocket max, and that's not stuff that I'm very versed in, but that's obviously something you have to look at too. So once you looked at it, you said the client does have coverage at your facility, you're going to start with the pre-authorization and intake. And as I mentioned before, there's, depending on the insurance company, they do have different processes, and the longer you do this, the more knowledgeable you'll become. There are For about, I'd say 95% of insurance companies, what you're going to do is admit the client and then do an assessment within the first 24 hours and then call the insurance company and do the pre-auth process. There are certain insurance companies, most notably that I can think of, BCBS Federal, which does have very specific rules that you need to follow prior to the client coming in, or they will not cover anything. And then there is Regents, which requires authorization prior to admit. And there may be one or two others out there as well. But that will also be determined when you do the verification of benefits. It'll say this policy requires auth prior to admit. So you either do the assessment prior to admit and get them authorized, or most of the time you're going to have them come in, do a full assessment, and then call in the insurance for intake. And that process can either be you call the phone number, you review live with a case manager who's also either a nurse or a clinician there and talk about the case and kind of argue or present the clinical, present the timeline and kind of really show why this client needs that level of care. They'll make a determination. And of course, you're going to get authorized because that's the goal. And then after that, we have the concurrent utilization reviews. And again, depending on the insurance, it kind of dictates, and also the medical necessity and the clinical, how often you're going to be reviewing. So you could be reviewing, with a company like Cigna, who has higher medical necessity. BCBS of California also has higher medical necessity. UVH, depending on if you're in or out of network, they kind of have different review policies, but you may be reviewing a little more. I've had cases where I reviewed every 3 to 5 days, 2 to 3 days, which can get, it can be a lot, especially for the clinician as well, if they're having to write URs. And that's another thing. You want to get a solid UR form for your clinicians to fill out when they have a client that's due. And, you could either work with a UR specialist or a billing company to kind of figure out, or based on your knowledge, what insurance really is looking for. And we know that there are specific areas you have to hit for each level of care to prove ongoing medical necessity if you are requesting more time. And how concurrent and utilization reviews work, again, it'll either be fax in, you will, or in cases like Cigna requires live reviews, which means you'll schedule a date and time with the case manager and you'll hop on live and discuss the case. Or with like UBH or Anthem or something like that, you will call and likely just leave a voicemail for the care manager with the clinical information, and they'll call you back either wanting more info or stuff like that. So there are different types of utilization reviews. And then discharge. It's always really important to provide that discharge summary and discharge information to insurance so that they know that they can close the case out. It's also, this process is also, especially when you've done it for a long time, is developing those relationships with care managers. Sometimes a certain care manager will be assigned to a specific facility at the insurance, so you're going to be working with them a lot. So it's really important to facilitate those good relationships. And sometimes when you do have good relationships with the care manager, they'll give you a few extra days if you need it, which is obviously great. So part of that, facilitating that good relationship, is providing discharge information, just calling them and be like, hey, the client discharged. They often want a client phone number, contact address, obviously the aftercare plans. Sometimes insurance companies require time and dates of the follow-up appointments. So anything that you can give them is great to foster and nurture those relationships, because you're probably going to be working with them again on the next client. So that's kind of how that works. Obviously, during this, you have your billing people billing those authorized days and things like that. So next, we have medical necessity and programming. So this is also something that I've been trained in a lot. I do a lot of trainings in the past I've done for other facilities, and now at Wasatch Crest with our clinicians and with our support team on documentation and what is really great, obviously buzz keywords, things like that. So requirements for various levels of care, and the various level of care that as providers at treatment facilities, we're going to be authorizing go Detox, residential, PHP, IOP, and GOP. So for Detox, we are not a hospital. I'm going to assume that a lot of you listening do not work for hospitals. If you do, a hospital detox is an acute level of care, meaning that they need to be hospitalized, often for acute reasons, seizures. They need 24-hour nursing and medical. That's not really what facilities are designed for. So what facilities do and what Wasatch Crest does is a social or non-acute detox. And obviously that's a higher level of residential care, but it's not in a hospital setting. So as far as medicalness, and I'm going to go over these briefly, I could probably talk about them for hours because again, I really enjoy this stuff, but we're just going to kind of do some brief medical necessity stuff. So for detox, we know that there are certain requirements as far as what substance you're detoxing off. So opioid detox can go either way. Obviously, we know that opioid detox, it's not as fatal as, maybe an alcohol or a benzo detox, but there can be complications with opioid detox, which can, validate medical necessity for authorizing that level of care. And what insurance companies are looking at is, first of all, is the client on a detox taper, meaning, Suboxone or Subutex or anything like that, that proves medical necessity that they needed to be monitored to go through that taper. Also, they look at vitals. Are the vitals elevated, right? And then with that, they look at co-occurring health disorders. Does the client, obviously, if they have some co-occurring health disorders, that could be made worse by a detox like hypertension or diabetes or something like that. That also proves some medical necessity for being in that level of care. And then they're also going to look at, for opioids, they'll look at the COW score, which is the clinical opiate withdrawal scale. And we know that, that's done by numbers, things like that. Obviously, the more withdrawal symptoms that you have, the higher your COW score, the more medical necessity there is for you to be authorized at this level of care. And generally for opioid detoxes, we usually see 3 to 5 days of authorization. That's kind of the standard. As far as an alcohol or a benzo detox goes, we know that those can be, fatal sometimes and more dangerous. So insurance companies are a little more willing to authorize those types of detoxes for those primary substances. And again, they look at the same things, the CWA or COW score. Obviously, the more withdrawal symptoms, higher the score, more medical necessity. They look at the vitals, always look at the vitals. And then, use patterns is very important. How long and how much have you been drinking or using benzos, or, with opioids too, how long and how much, because that's going to also kind of say what the medical necessity is. And then obviously, if you are on the taper as well, a Librium taper for alcohol, or a benzo taper or something like that, they definitely, want to see that medical necessity. As far as detoxing for like meth or cocaine or marijuana, we know that, yeah, your client may be a little irritable and have some physical discomfort and things like that, but that doesn't really require medical necessity. And so generally those types of detoxes are not authorized by insurance companies. Again, I have seen them authorized for like a meth detox before, but that's because we were able to prove that the client had, they had a co-occurring disorder, vitals were off the charts, stuff like that. So again, we go over these, but every case is different. So that's what detox is. As far as residential, and for residential, especially, the benefits that we use to authorize our clients are short-term stabilization benefits only. And I think that sometimes as clinicians, which I am, I do the insurance, but I'm also a clinician, we know that statistically a longer residential stay, we want 6 days, we want 90 days, but the benefit that we're using for authorization is not designed for the longer term. Now, there are outliers. There are certain insurance companies that will give you that amount of time, which is great. Better benefits, stuff like that. But for the majority of the benefits that we're going to be using, generally a really good length of stay authorization is about 30 days. And that is proving medical necessity the whole time. And when we look at each level of care, what we need to kind of tell the insurance companies and when we present our case is, why can't this client be treated at a lower level of care? Why is it going to be dangerous or life-threatening or stuff like that to step the client down at this time? So that's kind of what we're proving when we do our utilization review, right? In this area, in this area, in this area, maybe the client has high cravings. We don't want to step a client down when they have super high cravings, because that obviously we know is probably going to make them more likely to use. I had a good relationship with a care manager at, I think, Cigna, and she, when you do have these good relationships, they try and work with you to give you authorization. And she told me once that what they're looking for at residential is, does the client have coping skills, but they're unable to utilize them without intervention? So that's always a great thing to say, the client's working on XYZ coping skills, but when they get in distress, they're unable to use them without staff intervention. That can prove why they need to be at a residential level of care. So there are so many nuances. Again, I could sit here for hours talking about it, but we don't have hours. So that's what it is. And so for residential, I would say a really good authorization, just generalized for all insurance companies, is about 30 days. Certain insurance companies with higher medical necessity, like Cigna, you're really lucky to get 15 days sometimes. And certain insurance companies can get a little longer, but that's what it is. PHP is also a level of care that we do see shorter authorization periods with, because again, insurance looks at it as a stabilization period. And that's PHP requirements are similar to residential, but they're not, as the client isn't in as much distress and they're able to manage their lives a little better. IOP, generally we do see longer authorizations with. Certain, like for Cigna, what they do is they provide basically 30 session blocks. I think Cigna, you can use them a period over 90 days. Like Select Health gives 35 session blocks. If you're in network with Molina, there's actually no authorization required. So again, it just depends on what insurance company, but with somebody like UBH, they have definitely require more of a frequent review. Maybe they'll give you 6 sessions at a time. So again, it totally depends on insurance. It depends on your client's presentation. When we review for IOP, relapses, we know part of recovery, and we know that people at the IOP level of care do sometimes relapse. So that's really important to note, because obviously if the client has a relapse, that can prove medical necessity, that they need more time at that level of care. GOP is general outpatients, individual sessions, generally 45 minutes or less. There's a CPT code for group sessions. And I say 99.9% of the time it does not require authorization, so you just bill. In my years of doing this, maybe a couple policies I've seen authorization needed for GOP, but it's basically a really easy authorization process, and they give chunks of sessions at a time. So that's kind of how medical necessity works. And moving on, how to advocate effectively. So as I kind of mentioned, there's insurance nuances, and it's knowing how to advocate for that particular insurance company while using medical necessity. There's different requirements for all of these different insurance companies. Some have more medical necessity, some have less. Also, different providers. Once you've been doing this a while, you're going to know what specific insurance companies request, how they do everything. Like with Molina, I know that they don't backdate, not even 1 day. So if we have a Molina client come in, I know that we need to get that assessment done within the first few hours, and I need to call that in so we don't lose billable days for the client. So negotiation is a huge one, and something that's worked really well for me. So when you can kind of tell, based on the feedback that you get from the care manager, when they're kind of reaching the end of that off period for that level of care. So sometimes, in working with the clinical team, you can say, hey, let's keep the client for this day, and on this date we'll step him down. And having that plan to negotiate with insurance has been extremely helpful. And sometimes they'll give you those few more days when maybe they were planning on denying or something like that. If you say, give us these few days, this is what we're going to work on. You always have to say, why you need those days. This is what we're going to work on. This is the plan afterwards. And sometimes they're more willing to do that for you. Again, that also speaks to the relationships that you have with the care managers at the insurance companies. And finally, parity. Parity is a word that kind of gets thrown around a lot because of the Parity Act. I don't have it pulled up right now, but essentially the Parity Act came and said that mental health and behavioral health insurance benefits cannot be more restrictive than regular medical benefits. That's a very broad statement. So some people call and they say parity. I've tried to throw that word around before, and people, well, how can they do that? There's parity. I think that the benefits have gotten better, but I do not think that they're equal to medical benefits yet. For example, let's say somebody goes into the hospital, right, on their insurance benefits, and they're having a heart attack, and the emergency room says, oh, I'm so sorry, this is your second heart attack this year. You were only allowed one heart attack that's in your benefits, so we can't treat you because you can't have another heart attack. Now, when we look at behavioral health benefits, you have a client come in for their maybe fifth or sixth treatment of the year, and insurance looks and says, well, they've had a lot of treatment this year, I just don't think they're dedicated, so we're not going to cover. And that definitely happens. So while I think parity is a great thing, I don't think that it is the benefits are equal yet. So there's definitely that. So that is something I just wanted to touch on as well. So denials are something we're totally going to get all the time. And how do we deal with denials? Well, peer-to-peer reviews, most insurance companies and most policies will offer a peer-to-peer review. And this is kind of my go-to. The goal, at least my goal, is not to have any unbillable days, but sometimes when we do get a denial and we believe that the client does meet medical necessity, we can form an argument, we can talk to the doctor, I'll request a peer-to-peer review. And what that is I've always been able to do them. I've actually never had to have a doctor do it, actually maybe once or twice, but I've probably done hundreds. And so what I do is, since I'm a master's level licensed clinician, I am able to do the peer-to-peer review with the doctor, and I will speak with the doctor of the insurance company. And usually this happens with 24 to 48 hours. And again, if you do a peer-to-peer review, there is that risk of missing those billable days. But again, it's about preparation, it's about knowing what to say, it's about focusing on the medical necessity. So you'll get to speak with the doctor. I've had 30-minute peer-to-peer reviews, I've had 2-minute peer-to-peer reviews. I keep a record, it's about 50-50, yes and no. And again, that negotiation is great with doctors too. You give us these few days, this is our plan. So that works as well. Written appeals is something that I don't recommend because you're taking a huge risk. Written appeals generally, you have like a certain amount of time period, generally like 30 days, and then they can take 30 days to get back to you with their determination. Written appeals have a very low win rate. So again, it's not something I recommend, but you have to, again, look at the case. Is the client going to stay at this level of care regardless of what the insurance says? If the answer is yes, then great. Keep the client, then do a written appeal when it's, that length of stay or that level of care is done. Figure out what you need to do. It's generally sending in the medical records, writing an appeal, and you have that at least. So again, it's basically a case-by-case basis as to how you want to handle denials. Or if you just want to do a step down, that can help. That can be great too. So any questions? I am available for questions.
Thanks, Lindsay. That was great. As a reminder, everyone, you can ask questions by using your GoToWebinar control panel and typing it in there, and we'll make sure they get answered. Before we jump into that, Linz, will you just move to the next slide and I'll preview some upcoming webinars? So this is our upcoming webinar schedule. We're trying out a new time, Fridays at 9 a.m. We were originally doing them on Wednesdays. So next up on October 16th, we'll be talking about admissions and how to effectively get clients into treatment. Our Director of Admissions will be presenting, Jessica Cuddington. On October 23rd, our Clinical Director, Rich McDonald, will be talking about efficient healthcare provider communication. So just keeping that primary provider in the loop while their client is in substance abuse treatment and how to best do that. And then November 20th, Tyson Allred, our transitional living manager, will be talking about curating a sober living experience. So kind of how he works with our transitional living clients to help them get ready for life after treatment. Okay, so we can go ahead and go back to those questions, Linz. I'm not seeing any questions right now. So I guess we'll just wrap it up and we won't take too much more of your time. Lindsay, will you go to the next slide?
Yep, there you go.
So that is our 24/7 admissions line and then our website, wasatchcresttreatment.com. So feel free to either give us a call or visit our website to learn more about our programs. Thank you everyone for joining us today. And thank you, Lindsay, so much.
Thank you. Thanks, everyone.